I am Dr. Nik Nikam from Houston, Texas, and today we are going to focus on the United States response to COVID-19 from January until October 2020. This is going to be an important topic. I would like you to please stay till the end of the presentation so you will be knowledgeable about how the United States has responded to the COVID-19 pandemic and how do we explain some of the outcomes that we have seen and what things could have been done differently. So let us begin. Before I proceed, I would like you to take a look at my book on COVID-19 pandemic, which is going to be available on Amazon.com in November. Thank you so much. As of October 21st, 2020, there are more than 39.7 million cases of coronavirus all across the globe with more than 1.11 million deaths. But now we come to the United States. In the United States, we have 8.5 million people who have tested positive for the coronavirus, accounting for 226,149 deaths. By just looking at these two numbers on the surface, most people would think that the United States has the highest number of active corona cases for a country, and the United States has the highest mortality compared to that of any other country. I am going to disprove that to you during this presentation based on scientific facts. Just looking at raw numbers and twisting those numbers to make a narrative doesn't make it a fact. So what you are going to hear in this presentation are based on facts and figures which you can verify by visiting the websites from where we have received these raw data. Keeping that in mind, the incidence of 8.5 million may seem like a very high number, but in the coming slides, I'm going to show you what it actually means. But before I do that, I want to look at the current status of the COVID-19 all across the globe, so we have a better understanding of where the United States stands and how it is responding to the COVID-19 pandemic. At the present time, the world data shows they are recording more than 400,000 cases per day of new COVID-19 cases. At the same time, they are also recording 5,000 to 6,000 deaths per day all across the globe. This 400,000 is not a small number. We're going to look at the numbers for the United States and we'll compare that and see what we can infer. As I was mentioning, we are talking about 8.5 million cases of COVID-19 in the United States. May seem like an astronomical number, but don't let these numbers deceive you. Before we go and dwell as to why are we having such a high number of active coronavirus cases, why does the United States have a mortality of 226,000 cases during this pandemic, and what is driving that mortality? And how does that power, the driving power, differs in the United States when compared to comparable countries across the globe? Let's talk about ethnicity. The United States population is primarily made up of the people who immigrated from the United Kingdom and the European Union bloc countries. We also have Hispanics and we also have African Americans. So we're going to look at each one of these and see how they can affect the overall incidence of COVID-19 and of course the mortality and the outcomes. Then we'll talk about the number of tests performed. The more tests we do, the more people are going to show up as positive, but that is no indication of how severe the virus pandemic is if it is not creating significant problems in terms of morbidity and mortality. Of course, people will argue about that too, because the United States has registered apparently the highest number of death rates, but that we are going to look into in a minute. Then we also have to look at some variations in the population. The younger people have a much milder incidence of infection, much lower incidence of COVID-19 infection compared to people 60 or older, and how it correlates with reference to United States and other countries. We are also going to look at some of the risk factors like diabetes, heart disease, hypertension, which can significantly increase the risk of acquiring COVID-19 infection, and at the same time having a much higher incidence of going into the intensive care unit and higher death rates. Most people don't talk about population density, and I'm going to show you a relationship between the population density and the mortality. Because when I am talking about all these variables, ladies and gentlemen, I want you to focus an important point which I'm trying to make. That is, there are what are called fixed variables, and there are what are called variables that can be altered. Like in your house budget, your rent is a fixed variable. You cannot change it. You can downsize your apartment, but your rent is fixed. Similarly, your insurance premiums are fixed. So those are fixed variables. The money you spend for the restaurant, it can be variable. You can cut down going to the restaurant and reduce that cost. But here we are talking about the age group, which is a fixed variable. It doesn't matter who is running the COVID-19 program. It doesn't matter what state you're in. You can change these variables. You can't change ethnicity. You can't change the age group, and you cannot alter the pre-existing conditions. Also, the population density, which I'm going to highlight. These are all what I call fixed variables, and these variables are some of the ones which are primarily driving the high mortality here in the United States, and we're going to look at real examples to substantiate those points. Self-mitigation, regard and disregard. This is a variable that we can change. If we take very good precaution, we have a very good chance of keeping ourselves from getting infected. But if we disregard the self-mitigation guidelines and run around in large groups and other kinds of activities, we are going to be exposed to the virus, and very likely we'll end up getting the COVID-19 infection. And we have seen such actions during lockdown and post-lockdown periods. And there are also cultural differences unique to the United States, which you may not see in the comparable countries like the United Kingdom or the European Union bloc countries. And of course, we had some disruptive things going on all around the country, such as strikes, very large gatherings without self-mitigation guidelines, and of course the protests. Anytime there is a large gathering, it doesn't matter for what purpose it is, there is an increased chance for spread of COVID-19. So this is sort of an introduction to the entire topic. I'm taking time to explain this because we need to underscore there are some fixed variables, there are some variables that can be altered, and how we can change these to get a different outcome. Now let's begin with ethnicity. As I told you, most of the descendants in the United States, the original descendants, came from the UK, European Union bloc countries, Hispanics, and of course African American people. If you look at the population distribution as of 2019, 63% of them were non-Hispanic whites, predominantly those who came from Europe and UK. and we have 15% of the population which is Hispanic, and about 13% of the population which is African American. But let's remember that the people belonging to the Hispanic group and the African American group also had a pretty high incidence of being admitted to the hospital, and also had a higher incidence of mortality related to the COVID-19 pandemic. And of course, we have the Asian population, the Native American and Alaskan, all of which make up a small percentage of the United States population. Let us continue. Let's talk about the number of tests performed. The United States population is 331 million people. So far, the United States has conducted 128.6 million tests, which accounts to 38.7% of the population. That's close to 40% of the population have already been tested for COVID, of which 8.59 million people have tested positive. That we are talking about 2.6% of the population that has active COVID infection as detected by these tests. If anyone says we are not doing enough tests, we are not doing adequate testing, that is not an accurate statement. Because when 38% of the population has been tested, of course, we need to do the test for the remaining 62% of the population, but this is a very large sample of population to understand the COVID-19 pandemic and its effect on the population. This 2.6% is a small number. It's also sort of like a double-edged sword. We have a very small percentage of people who are infected. That means chances are there are more people who could be vulnerable to the COVID infection in the future, which emphasizes the fact that we need to continue self-mitigation guidelines and hope for a vaccine or whatever the treatment might come along that can provide long-lasting immunity. Now let us begin with some real hard facts. First, I'm going to take United States, then I'm going to run through some of these countries here. And most of the countries that I have chosen are from Europe, namely the United Kingdom and some of the European countries, because the majority of the population here in the United States descended from these countries. Let's talk about the United States. We talked about the total number of cases, the mortality, and United States population of 331.6 million people. The number of tests done, of course, is 38.5% of the population, and the mortality in the United States is 682 per million population. Unless we index the population to a standard population size, it is meaningless to take the raw numbers and say, well, the United States has the highest mortality. We have 5% of the population in the world. We have 20%, 25% of the deaths from COVID in the United States. I'm sure you must have heard on many media outlets, but that is misleading the people. That is misguiding the people, because it is not really telling what is the truth. The truth is, when we compare one country to another country, they have to be standardized to a certain number. The best number you can use is how many people per million population, or how many people per million people who test positive. So these are some good comparisons to make. In this presentation, we're going to be sticking to the instances based on per million population, which will give us a very good index of how the United States stacks compared to other European countries and the United Kingdom. Okay, let's talk about, for example, UK. And Brazil and all these are not in the EU countries. So let's talk about UK. UK has a population of 67.99, which is 68 million people. It has done about 443,000 tests per million population. The total tests done here are 30 million population, which is almost 50%, 44% of the population, which is very good. But look at the mortality here, 647, which is not very far from 682 we have seen in the United States. But remember, we had a large number of people who died during the early phase in New York City, which has a totally different set of problems, which I'm going to be talking about in a few minutes. When you compare these numbers, now the United States mortality doesn't look like astronomically out of this world compared to other countries. That is not true, because the United States mortality is 682 per million population, and that in the UK is 647 per million population. Let's go down the line. Italy, which also had the biggest threat during the early phases in March and April, it had 36,000 total mortality, and its mortality rate was 607 per million population. See, they are all pretty comparable. Let's look at Spain. It has a population of 46 million, but its mortality rate is 732 per million population, which is much higher than the mortality rate we have seen here in the United States. I am sure most other places you're not going to see this one. That's why I am trying to reinforce my presentation with hard facts, real data. All of these data are taken from worldometer.com. Okay, we talked about Spain. Let's talk about France. France has a slightly lower mortality, but still over 500 deaths per million population. And look at all these European countries. Their populations are ranging between anywhere from like 10 million to 60, 70, 80 million. Germany is the only country, I don't know if I see Germany here, but Germany is the only country which has a population of 83.9 million people. You get the idea that even though the total number of deaths in other countries may be in tens of thousands, but when you compare them to a million population index, they have a mortality, some of which are higher than that of the United States, some of which are slightly lower compared to the United States. So in summary, the United States doesn't have the highest mortality per million population compared to many countries in the European bloc. We also going to talk about Belgium, which is not listed here. In fact, Belgium has a mortality of 904 per million population, which is the highest in Europe. Now you have a better understanding of how the mortality correlates with different countries when we index them to a 1 million population size. In the introduction, I talked about people who are over 60 years, who are more prone for developing COVID-19 infection, who are more prone for developing complications related to COVID-19 infection, and who most likely have a much higher mortality. So let's look at how it impacts and why we see a higher mortality in the United States based on the population over the age of 60, because let me show you what I'm talking about. First of all, as people get older, more people are admitted to the hospital with COVID-19 infection. Here, the rate 100,000 population, this was back in July 2020. The age group less than 30, you have less than like 25, 30 people admitted, whereas here it's 620 times higher admissions to the hospital with COVID infection in people who are above 60. It goes up from anywhere from 10 to 20 times higher. All right, that's just about admissions. Let's look at the mortality. If we say the mortality is 1 in patients below, as index number 1, below 29, the mortality of people between 60 to 69 is 32 times higher than the mortality of people less than 29. And it goes up to 76 times, 100 times by the time they reach 80. So what does this all mean? The older people, they get sicker, they die. But that's not the important point. The important point I want to make is here in this particular chart. This is a very important chart. This explains why we had such a high mortality, especially in the initial months of the COVID-19 here in the United States. And when we understand this chart, we have a much better understanding of why the United States had a higher mortality. Okay, let's begin with. First of all, we know the United States population is 331. 20.7% of the US population is over the age of 60. So we have an absolute 68.7 million people who are above the age 60. We had deaths which were 226,000 and a mortality rate of 685 per million population, which is fact. We already know that, and there's nothing we can change about it. Now let's begin to understand other countries. Keep this number in mind, 68 million people who are above the age of 60. And as you can look at here, Italy, UK, Spain, France, Belgium, Germany, they all have a population which is close to 60 million. The number of people in the United States who are over the age of 60 exceeds the population of some of these European countries. Now you can see why we had such a high mortality to begin with, because we have a very high number of people who are above age 60. We are not just talking about percentages like here. If you look at the percentages, these percentages are pretty much similar. But we are talking about the absolute number of people who above the age 60, which has made a tremendous difference in this number. And that is an important number which we need to keep in mind. That is an important fixed variable. No leader, no healthcare expert can change people's age or their risk factors. So let's keep that in mind. Now let's look at Italy. 60 million population, 22%, almost 2% higher than the United States. There's only 13 million people who are above age 60, and still it had a mortality of 609, which is very close to that of the United States. Let's look at Spain here. UK, which is also similar, which is very close to the mortality rate of the United States, and they had only 12 million people who are they had 12 million people who were over the age of 60. Spain, let's look at Spain here. Spain had only 9 million people who were above age 60, and yet it had a mortality of 735 per million population. So if we normalize that to the United States population of 331, now we begin to see there are several countries in Europe which match the mortality rate seen in the United States. Let me restate it again. If we take the Italian population of 65.5 million and multiply that to reach a US population of 331, the overall mortality you would have projected would have been 201,000, which is close to the United States mortality. But there are other countries like UK, which is 214,000, if their population had been close to that of the United States. And if you look at Spain, if the population of Spain was close to 331 million, its mortality would have been 243,000, much higher than what we are seeing here in the United States. I am not saying they are not doing better All I'm saying is these are fixed variables which nobody can change. And this is how a virus pandemic, when it attacks older people, when it makes older people more sick, there are going to be more people who are going to be admitted to the hospital, who are going to be in the intensive care unit, and who are going to die. And if you have 68 million older people, there is going to be a much higher admissions, many more people in the intensive care unit, and much higher mortality. That has nothing to do with the healthcare system, the administration, or the people who are trying to minimize the risk of COVID-19 spread. Of course, if we use self-mitigation and keep ourselves protected, we could, to a certain degree, reduce the mortality. But let us not forget, in January and February, when the COVID was just beginning to come to the surface, we heard from the healthcare experts, several of them, in the White House briefings, that the mortality in the United States could be as high as 2 million. I'm talking about 2 million. Go back to the YouTube and look at some of the earliest White House briefings. You see they had projected the mortality could be as high as 400,000 or even 2 million. So the mortality we are seeing today is a fraction of what possibly could have happened if we had not done all the interventions that has been done so far to keep the mortality at 226,000 and not 2 million. Okay, let's look at a couple of other countries here. Belgium. We talked about Belgium, and everybody is curious about Belgium. Is how in the world did Belgium have the highest mortality? There are two major factors. One which I already talked about, the population density, which was 904 per square mile, something like that. Or the death rate was 904 per million population. But look at their age. They have the highest percentage of people over the age of 60. But since its population is only 11.6 million, the total number is 2.85. If they had 68 million people, or if you take the Belgium and bring the population to 331, they would have the highest mortality in the world with 299,000 cases. Of course, these are hypothetical situations, but what I'm trying to explain is there are some factors which are driving these mortalities, namely the ethnicity of the people, the age of the people, and the risk factors, which we're going to be talking about in a few minutes, and the population density, which we will talk also. All right, let's talk about the risk factors. When Italy was going through this horrendous influx of patients who could not be managed in the intensive care unit because there were no beds available to these patients, they recognized that those patients who are older than 65, who had hypertension, diabetes, and heart disease, their mortalities were close to 75%. So there's no question, when you get a patient with these coexisting conditions, pre-risk factors, the mortality is going to be high. In Europe, altogether, based on the European Society of Cardiology, 1 out of every 5 European has risk factors like cardiovascular diseases, obesity, and hypertension. You think that's high? 20% of the people have these risk factors. We already saw that in the chart. But what about the United States? It's a totally different story. Again, this is a fixed factor. No healthcare executive or any expert can change these things. Hypertension, 49%. Obesity, 48%. Diabetes, 29%. Cardiovascular disease, 28%. We got 30 to 50% of the population with these risk factors. And when these people get sick, obviously we're going to have higher mortality. This is in no way reflection to what is being implemented to reduce the mortality. All the things that need to be done have been done. Lockdowns have been done and self-mitigation guidelines have been laid out. But we just have a population that is not very healthy, a population that is more vulnerable to the COVID-19 infection. They are more vulnerable to severe infections and more chances of going into the intensive care unit. So these are important factors to keep in mind when we are talking about the incidence of COVID in the United States and the high mortality numbers which everybody wants to talk about it. All right, self-mitigation, regard and disregard. Who would have ever thought that the Fifth Avenue in New York City would be void of a human being? I have been in the United States for almost 43 years, but I have never would have imagined in my life that we are going to see a lockdown of New York City of 9 million people. But it was successful, and when the lockdown was done, the mortality rate was low. The infection rate was low. But of course, New York City was the first city that was caught off guard, and there was widespread COVID-19 infection, which resulted in a number of patients not being able to get into the hospital, not being able to get the healthcare services. That's a different story. But after the lockdown, number of cases and mortality came down. So definitely self-mitigation rules and lockdowns work. But there are instances, self-mitigation. There are countries which had no lockdown and had similar reduction in mortality or much better reduction in mortality. But when we compare those countries to the United States, we have to keep in mind some of these points I've been talking about. The age group, the cultural differences, the ethnic background, and also the social aspects, which we're going to talk about also. Masks do work, yes. Hong Kong, Japan, South Korea, New Zealand, Australia, Taiwan, China, all these countries have clearly shown that wearing masks, hand washing, and maintaining distance reduces the spread of COVID-19. We also had results from the lockdowns when we had these followed religiously here in the United States. But however, when the lockdown restrictions are lifted, people head to the bars, beaches, and clubs. And of course, with that comes the spread of COVID-19 infection. I also heard about people having COVID-19 parties to just get the infection and get it over it. Who wants to sit and wear the mask and do all kinds of stuff for 6 months or a year? I don't want to do that. I mean, that's what the younger people wanted to try. I heard about these COVID parties, but I've never seen one, and certainly would not want to participate in one of these COVID-19 parties. Oh, hell no. Then we had the Sturgis motorbike enthusiasts meeting, which involved like 500,000 people. And in fact, it has been shown by studies, those people who came from certain regions of the country to this particular area had a 12% increase in the COVID infection after they returned. So there's no question, when people gather together, there's going to be an increased spread, especially when they disregard the self-mitigation guidelines. Similar instances have been found in UK, in France. They also had strikes in Germany, protests, and of course, United States was unfortunately hit with strikes and protests after George Floyd died under the hands of a police officer. That's a sad, unfortunate story, but it certainly needs to be mentioned because it has some relationship to this COVID-19 pandemic. During that time, there were protests all across the country in all major cities where people were gathering in large numbers. We don't know how much it contributed to the spike that we saw after the lockdowns were lifted, but these are all important things to keep in mind as to why we have a higher incidence of mortality. And in Texas, I can tell you for sure, because I live in Texas, the lockdown was lifted towards the end of May, and 2 weeks later, we had the second spike here in Texas. And the interesting story about Texas is that when we had the second spike, it was clearly an affirmation because during the second spike, 40% of the admissions to the hospitals were people aged 20 to 40, which we rarely had seen during the first wave here. That means this was clearly related to people intermingling together, disregarding the self-mitigation guidelines, which resulted in younger and younger people getting infected and admitted to the hospital, and also even going into the intensive care unit. So during the second spike, we had as high as 12, 13,000 cases per day. And this is a clear reflection of how mitigation works and how lack of mitigation can turn into an explosion of new cases of COVID-19. Anyway, luckily this wave is coming down, but it is still nowhere close to what it was in the first wave, when we had maybe an average of 1,800 cases. But even now, Texas is recording close to 3,000 to 4,000 to 5,000 cases per day. Cultural differences. Of course, each country has certain liberties. Each country has certain tolerances. Here in the United States, people are very, very passionate about their first right amendment, freedom of speech. People are passionate about their second amendment, freedom to bear arms. As a result of this, people had the right to join large gatherings, protests, strikes, whatever they liked. And we have seen that happen in the United Kingdom and also in certain EU countries. Whenever there is large gathering, there is an increased risk of COVID-19 spreading and thus increasing the number of cases. Population density and COVID-19 incidence. Population density is something that most people don't talk about, but I can tell you with certainty that population density had a significant role in New York City in accounting for a large number of deaths. There are several examples. First, let's look at globally, and then we'll come back to New York City in particular. In New York City, the population density is 26,403. And we know all these high-rise apartment complexes with very, very narrow spaces, common airways, elevators, common hallways are a perfect recipe for spread of COVID-19 infection. The death rate in New York City was 1,723 per million population, which is far higher than most other countries, including the United States itself. They had a 33,500 deaths, which is almost close to the number of deaths seen in many European countries. But the New York State population was only 19.5. And this high death rate in New York City was related to several factors, the most important of which was the population density. As these people, especially during lockdown, as they were all crowded in their small 300, 500 square foot apartment, they had nowhere else to go. They had to use a common air conditioner, common hallways, common elevators. So they became the biggest source of COVID-19 infection. Right after the lockdown was lifted, according to New York Governor Cuomo, 60% of the admissions to the hospitals with COVID infection came from these lockdown places. So that clearly tells population density has a significant role in increasing the COVID-19 infection rate and increasing the mortality. And one more country where I want to focus is Belgium. With Belgium, I talked about the aging population. The second point is the population density. In Europe, compared to Italy, UK, France, Germany, Sweden, Belgium has a population density of close to 1,000. And that also probably was responsible for its mortality of 10,489, or a mortality rate of 904 per million population. So keep in mind population density the next time you talk about mortality and infection rates in any part of the world. Before I finish this, I also want to tell you Mumbai, which also has a very high population density, which is, I think if I remember correctly, was like 40,000 per square mile, also has recorded the highest number of COVID incidents and deaths in India. So to look at it from a different angle, here are some countries which had a death rate of over 1,000, like Peru and San Marino, but Belgium is 900. We talked about Spain, Brazil, Bolivia. United States is number 10 when it comes to mortality per million population. So if you hear that United States is number 1 in number of deaths, that is a wrong information. That is half information. Yes, we have the total number, which is highest, but we also have the third highest population in the world. So let us not forget that. Let's continue. COVID pandemic to case-demic in the US and Europe. There has been a little shifting paradigm in the month of October as far as COVID-19 is concerned, but nonetheless, it is increasing great anxiety in the minds of healthcare leaders, politicians, media, and of course, the population. What is this new phenomenon? What is driving this new phenomenon, and how do we interpret this? COVID pandemic to COVID case-demic. Let's explore this one further. If you look at the map here, this is United States. We had the first wave here, then it settled down. The second wave came here with the rates 3 times bigger than the first wave. It came down, and we are seeing a third wave, ironically, only here in the United States, but in most other countries it is just still in the second wave. But nonetheless, we have the number of cases here in July and August, which is 3 times bigger than the number of cases back in March and April, and still the mortality is half of what we saw in March and April. So what is causing this disparity? We have an astronomically rising number of new cases, while the death rates are lower or almost disappearing in most European countries. And we're going to look at those. Okay, here's an example from Japan. Japan had 3 times the number of cases in August compared to that in April. But look at their mortality. It's hardly anything. So what is happening here? How come we are seeing 3 times the number of cases, but the mortality hasn't changed? Has the virus changed? Has the disease course changed? What is driving this high number of cases, but with no appreciable effect on the mortality? Okay, here's France, an identical picture. Increasing number of cases, decreasing number of deaths. All right, here's another one. Germany, same story. Germany had 7,500 cases during the first peak. It is registering 7,500 cases during the second peak. But we're not seeing the same mortality like we saw here in April. The mortality is probably in double digits. What is driving this significant increase in cases with no change in mortality in most European countries and here in the United States? Here's United Kingdom, which kind of mirrors what we saw in France and Germany. Now let's look at this is New York City, which has increased number of cases here, but negligible mortality numbers. That's interesting. Let's look at how do we explain this. First of all, let's look at an important aspect. We are doing more tests. Of course, we are going to see more number of cases. So that doesn't mean that everybody is sick, since 80% or more are going to be simply mildly symptomatic or no symptoms at all, and they can just recover at home. We have also seen an increase in percentage of cases testing positive. That may be alarming, But as long as there is no increase in death rate, it shouldn't be really shocking, because hopefully these people will get over the infection and in the process will develop some immunity. I think another culprit in this spurious rise in cases with no change in mortality or decrease in mortality has to do with this PCR test. The PCR test that is widely used all across the globe not only detects the live virus, it also detects the dead viruses, the viral RNA particles. So in other words, when you do a PCR test, they say, oh, you're COVID positive. It doesn't mean that you always will have live viruses which you can pass on to other people. You could be having a dead virus which could also test positive, or you could just have remnants of the virus, the RNA strains, which are not going to cause the infection to you or anybody else. As a result, these viruses and virus remnants and dead viruses are giving a very high number of positive numbers, in addition to the fact that we are testing more people, and of course sometimes in some countries in certain times have had higher incidence of positive tests. I want to emphasize this fact because it is a knee-jerk reaction to say, oh, we are seeing more COVID patients, we should be doing more tests, we should be recognizing every person with the COVID infection, whether the virus is dead, alive, or not moving. Of course, we're going to have political pressures, but we need to understand the scientific background as to what is causing this. If people are testing positive, and if the mortality is not changing, then maybe they will get a milder form of infection. But how do we reallocate our resources? That's an important point I want to emphasize when we are seeing more and more cases. And of course, here in the United States, there is more push for case recognition and for contact tracing. Contact tracing, it's an enormous job. In a country with a 331 million population, we will need more than 600,000 trained caseworkers to track these people. But people may not be interested in giving the information. People may not want to share the information. As a result, it sounds like a novel idea. You can do this in China, because in China they are tracking 9 million people. But you talk about tracking 300 million people with COVID infection to see who has the infection and if they're going to stay home so that they are not spreading it to the other people. It is a mammoth task. It doesn't mean we shouldn't attempt it. We should attempt it, but we need to be realistic, because in a very large country with diverse people, with diverse concepts and rights, it is not going to be easy to reach those people. An important lesson we learned from this COVID-19 pandemic to COVID-19 case-demic is, in the initial stages, everybody is vulnerable. And whoever tests positive probably has active virus. So in the initial stages, the testing apparatus are very useful in identifying all cases of active coronavirus infection so that we can identify them, isolate them, quarantine them, and do the contact tracing of all the people they have come across. But after we had this initial wave, and when we have a better handle on the pandemic, when we start doing more and more tests, we may begin to see some of these tests not clearly reflecting a real active infection, but it may be just positive because of dead viruses or even viral remnants. Another important factor I want to emphasize here in the United States compared to other countries, especially the European countries, because when I did my master's in healthcare administration, one of my theses was healthcare administration across the globe. I studied the healthcare services in UK, France, Italy, Germany, Japan, and all these countries had some form of a national health service. They had one central body running the whole system. But that's not the case here in the United States, ladies and gentlemen. It may also be an important factor to reflect how challenging it was in the United States to implement certain standardized protocols. UK has the National Health Service. Germany also has a National Health Service. France is the same thing. And they can implement a particular protocol that will be going all across the country, which is a lot easier and a lot simpler than to have 50 different states trying to reinvent the wheel themselves and trying to find solutions. That's not the best option, but that's what we have to deal with. So the healthcare system in the United States is fragmented. It is different in different parts of the country. It is viewed differently by different leaders and healthcare experts, which makes it exceedingly difficult to coordinate certain aspects of the COVID-19 pandemic. And most of the healthcare system controlled by private insurance companies, private healthcare systems, and also by states. So to summarize, ladies and gentlemen, United States of America with a population of 331 million. There's a little typo here, 331 million. It is the largest country besides China and India. It has the largest number of people over the age of 60 years compared to many other European counterparts. It has a much higher rate of heart disease, diabetes, and obesity, ranging from 30 to 50% of the population. We have a fragmented healthcare system, and people are more concerned about their private First Amendment, Second Amendment, more so than wearing a mask at times, which can, when there's large gatherings or protests, or when self-mitigation guidelines are ignored, there's very little recourse that can be done. But let's look at the bright side. The United States has made galloping progress in the field of therapeutics. We have remdesivir, we have Regeneron. Of course, Regeneron is a monoclonal antibody. We have hyperimmune globulins, which are being tested in phase 3 trials. We have also dramatically reduced the mortality rate here in the United States in the last several months, despite these number of cases going up. Plasma transfusion has made an impact in reducing the hospital stay and perhaps reducing the mortality. There are approximately 6 vaccines that are in phase 3 trials all across the globe, 3 of them right here in the United States. So in a span of 8 to 10 months, we have gone from the beginning of a pandemic to developing great therapeutics and in reducing the number of cases, reducing the mortality, and being able to have vaccines available, hopefully in the next month or 2. I'm optimistic. That's why I say 1 month or 2. But just today we heard AstraZeneca had one of their participants did not make it. We don't know the details, but that's a different story. But looking from a broader perspective, 3 vaccines here in the United States, 3 elsewhere in the world, 6 vaccines, we should have some light at the end of the tunnel. And we have done the most number of tests. 33% of the population, 38% of the population has already been tested. The death rates could have been much higher. The initial projections, as I told you, were close to like 400,000 or 1 million. But we are nowhere close to that number. Of course, United States is one country which rose to the occasion, produced over 500,000 ventilators, and in fact it is supplying to the other countries. And we have the bed capacity to deal with these increasing cases of COVID-19. Yes, a lot more could be done. One area would be identifying the contacts and doing the contact tracing. But as I said, I have written this book on COVID-19. We have a whole chapter on contact tracing. This is not an easy job. It requires 600,000 new trained case workers. And again, we have this human factor, which may be a limiting factor when we are trying to do the contact tracing and calling people randomly who don't know us. It's not going to be an easy job, at least here in the United States. So, ladies and gentlemen, given all the limitations we have, given the population we are dealing with, given the ethnic background that surrounds us, given all the challenges we have with the fragmented healthcare system, state level management of COVID-19, I personally would say the United States has done well and is comparable to the UK and the EU counterparts' responses. You may not agree with me, which is fine. You may have your own points, but I have tried to lay out real facts as what was driving the number of cases, what was causing the mortality that we have seen here in the United States. Of course, there is room for improvement, and hopefully we will have a vaccine and see some sunlight, hopefully this year or early next year. I am Dr. Nik Nikam. You have been watching COVID-19 World News special focus on the United States response to COVID-19. And please do check out my COVID-19 pandemic, which is going to be available in Amazon.com in November. And please do subscribe to our YouTube channel, and we will see you next time. Thank you so much for your attention.